discussions for today. What about Nisha Mishra, Zeba Faruqi, Manoj Das? Can you all put your videos on and can you be the discussants for today? Manoj Das, Nisha Mishra, Zeba Faruqi and Shashidhar Hegde. Okay. Welcome, Shashidhar.
Good afternoon, sir.
What about the other three? Sonali Avle, would you like to be a discussant? Sonali, can you put your video on? Come on, unless there are discussants, how will we proceed with the class? Someone has to come up as a discussant, no? Sonali, can you come up? There's another Sonali. Sonali saying, Harish, can you come up as a discussant? Come on, we need to start the class. It's 3:32. Please volunteer, or the people from whose names I have called out, please come up as discussants. Nisha, Zeba, both Sonalis, Manoj, Harish. Ramya Singrodia, can you come up?
Yes, sir.
Yeah, good. We need one or two more, please. Shashidhar and Ramya have been very sporting. Come on, who else is coming up? Priyadarshi. Ketki Shah.
Yes, sir.
Okay, Ketki, very good. Come up. Excellent. One more. Jimmy Jose. Excellent. Superb. So now we have 4 discussants. Shashidhar, Ramya, Ketki, and Jimmy. Of course, everyone else can also contribute at any time. So we'll start the class. As usual, it's going to be interactive. Sir, I'll share the screen, or you are sharing?
I will share the screen.
Okay, sir.
Shall I start sharing the screen?
Yes, sir. Yes, sir.
Well, I think, friends, let's get started. And as usual, I will give you an opening statement. And I will give you a clue how to go on thinking. Okay. And then leave it the platform to you to go on discussing, asking for more information. Now, this is an 8-year-old child who presented with fever for 8 days and developed bleeding from nose and mouth on day 5 of fever. Take a note of this. First 5 days or 4 days, there was only fever. And on day 5, he develops a bleeding from nose and mouth. There were no other complaints. Now, before I ask you to ask more information, let me give you a clue how you start thinking, because this is partly a teaching session and not just examining you like an examination. Now, please take a note that there is some bleeding from nose and mouth, right? And this has come after 4 days of fever. So start imagining what must be that fever in the first 4 days. Would you ask many more questions to get an idea what kind of fever that was? And then try to see whether this kind of a bleeding from nose is likely to be just a local bleeding or a part of a generalized bleeding disorder. If that is so, if it's a local bleeding, would there be any cause for that? What has the fever to do with it? If it was a generalized bleeding, was it platelet, coagulation factor, whatever? You get the whole idea how to start thinking? Now, let's start. One of you start asking questions related to what more information do you want. Anyone can start talking. Okay, any one of the 4, come.
So we would ask him any other complaints did he have? Like, was there cold? Was the child
Okay.
blowing nose hard?
Okay, why do you want to ask that?
So because the history of bleeding from nose is there on day 5, so probably the child had cold or any boil inside the nose that could lead to bleeding from the nose.
Okay, all right. Would that come after 4 days of fever?
As sir said, first you want to know what that fever is, because then you will be able to make out which of those types of fever could be connected to the bleeding. So first you want to decide about the fever. So ask all questions about the fever. So from the chat, there are comments that they want to know the grade of fever. They want to know onset, duration, progress of fever. They want to know whether child was good in the interfebrile period.
Very good. Now, let me give you some, but ask some more questions now. I will tell you what the fever was like. The child was absolutely all right prior to the onset of this illness. Fever was moderate. To begin with, interfebrile period looked reasonably fine, but the child was getting more sicker as the time went, which means subsequently the child was not as comfortable during interfebrile period. And there were no other symptoms. Now, what do you make out of this fever? You got the whole story? Moderate fever, to begin with, reasonably good interfebrile period, but getting more and more sick as the days went by.
What do you interpret, Shashidhar?
Sir, sir, history of any rash or something, and it is not high grade fever, and it's increasing activities are decreasing, and it is maybe because of after the 3 to 4 days child is getting more sicker and sicker, maybe any
Yeah,
viral fever.
So we are trying to make an attempt to decide whether this is viral fever, bacterial fever, some other non-infective fever, or a chronic infection or whatever. That we are just trying to make these groups if possible. From the chat, there are answers. Majority feel it's a bacterial fever. One person has suggested it could be viral, which is now getting into a complication.
All right. I think good suggestion, but let me ask you further question on this. Which bacterial infection starts with a good normal interfebrile period, but as the time goes, gets more and more severe, that he doesn't look fine in between fever? Would you know any such bacterial fever?
Sir, enteric fever. Enteric fever.
Enteric fever, very good.
Very good, good. Now, so we will keep in mind whether this is enteric fever, and you all know that enteric fever may not have any other symptoms whatsoever. That's fine. So that kind of bacterial fever we'll keep in mind. What about, though that fever also, we are not sure how severe it became. Okay, it remained moderate, but the child started getting sicker. So somebody else said viral infection with complication. Do you think that is possible?
So, viral infection with complication, it is possible if the child is immunocompromised or if the child is taking steroid for a longer duration. But viral infection with any complication like secondary bacterial infection is very unlikely in a healthy child.
So, Ketki, there is a suggestion that this could be dengue. So, is dengue does it get complicated in a immunocompromised child or in a otherwise normal child?
So, dengue can get complicated.
So, it is an example of a viral infection getting complicated even in a totally normal person, right? Okay.
Fine. So far, so good. We have said it could be a typhoid fever or it could be a viral infection, but not just a viral infection. It is getting complicated. And what complication? Not secondary bacterial infection. That is not common, but immune-mediated complication. So we'll keep that in mind. Now try to see whether this could be totally a non-infective condition. Well, that is also possible. So we will keep all these three possible things in mind. Now, does typhoid cause bleeding from the nose or mouth? What do you think? You must have seen typhoid fever.
No, sir.
No.
Very unlikely.
So that's unlikely. So let's get out of that. And we'll keep these two things on card. Okay. Now start asking. Yeah.
Sorry, sir. Could this be just epistaxis, the normal epistaxis which we see in children, idiopathic epistaxis, and he happened to have fever today or in this illness? What do you think?
See, what Dr. Rajesh wants to point out is many times in a very hot summer or even in a severe winter, one could bleed through the nose. Okay. And that is simply because those fragile blood vessels in the nostrils bleed out of such environmental change. Could it be simply that?
It can be epistaxis, sir.
All
But
right.
then,
Yes, go ahead.
So what are your reservations against calling it just that idiopathic epistaxis?
Sir, because there is a history of fever and also
Excellent.
there is
Very good. Very good.
that
So
the
that-
child is getting sicker.
Very good. So that means this is a pathological bleeding, right? And what is pathological bleeding? A bleeding disorder, right? Now ask more questions about bleeding disorder.
So your aim is to decide whether it's a platelet problem, coagulation factor problem, or a blood vessel problem. So you can ask questions directed towards this. Jimmy, what do you want to ask?
Sir, I would like to know whether there is any mucosal bleeds. Usually, mucosal bleed is seen in platelet problems, and in factor problems, you would see petechiae and other deep abscess. I mean, hematomas.
Correct. So mucosal means here they have said bleeding from the nose and mouth. So which
usually,
other mucosa you want to know? You want to know bleeding PR
Gum.
or bleeding per urethra? Are those mucosal bleeds or what?
No, sir. Here, the child is also bleeding from mouth, most probably gum bleeding, which is also seen in platelet problems. So it points out towards a platelet problem in this case.
Anyone else? Any other negative history would help you? You want to ask any history of the past?
So any past history of recurrent bruises and
Okay.
Fine. So I think, let me give you the information. It says moderate fever, interfebrile, getting sicker. Okay, no other bleeding sites. But he has high colored urine. There is no pallor. There is no jaundice. There is a mild abdominal distension reported by the parent. No past or family history of a similar illness. Now, what do you make out of this? What is this high colored urine likely to be?
So high color urine indicates presence of jaundice. This jaundice.
High-colored urine may be because of intravascular hemorrhage, or maybe it can be due to the bleeding in urinary tract. But if it is in a urinary tract bleeding, then it will be red, not high colored.
Oh. So possibly you wanted to know a little more about this high color. You wanted to know whether this was a cola colored, whether this was a frank red color, or whether this was any other color, right? And now I'll give you an information. This was a dark yellow urine.
Also, when you talked of intravascular hemolysis, you are right to think about that because the child is getting sicker and high color urine. But what else will happen in somebody who has intravascular hemolysis?
pallor will also be present, sir.
Very good. They will look pale also. Parents may complain of that and they may actually be shocky or whatever. Yeah, fine. So sir has said it is high color, yellow color, dark yellow. So somebody said dehydration. So can you talk for or against that? How will you sift that out? How will you make out whether it is dehydration only or something else?
If it was dehydration, then mother would have complained that the child is dull. And second, also the urine output has decreased as compared to every day. So mother would have
Excellent.
given.
Very good. So this child had a normal urine output. They have not reported. So possibly this is not dehydration. Again, a child at 8 years for a dehydration without loss of fluids is unusual. Just because he is not feeding well, that does not cause so much of dehydration. So now what does this yellow colored urine mean to you?
So somebody has said from the chat, conjugated hyperbilirubinemia.
Absolutely, absolutely. Why? We are not only discussing hematology, okay? So the commonest cause is that, well, if there is some pigments coming from diet, etc., that's different, but that's unlikely. So now possibly this child has got a direct bilirubinemia. Now, can you connect the two? You have a bleeding disorder on one side, and you have a direct bilirubinemia, probably. Now, how do you connect the two?
And you have fever for so many days.
Yeah.
So let us directly ask you, we already discussed typhoid. Can it be malaria? Malaria can cause jaundice. Malaria can cause thrombocytopenia.
So fever,
Or, yeah, Ramya.
so in malaria, we are not expecting daily fever spikes and moderate grade of fever. It is generally associated with fevers and chills and in the pattern.
Okay. So yeah, so you are saying that usually the pattern of fever in malaria is different. So that is not, you're not very comfortable with that. So there are other suggestions about rickettsia, leptospirosis, all that. So any thoughts on all this? So again, remember what sir started by saying. So suppose we first go back to the day before the bleeding, and we go even 1 or 2 days back before that. So in the first 3 days, did we think this was a bacterial infection? That could be one way to think about the whole thing, right? Amdekar sir.
Yeah, so I think what we want to say is that if so far before I told you about direct bilirubinemia as a possibility, you were talking about some infection, probably viral, which had an immune-mediated complication. Okay, and that caused a bleeding disorder. Now, at this point of time, tell me, could that have been a bleeding disorder out of platelet coagulation or a vascular problem? Then we will join direct bilirubinemia to it. What do you think? Could it have been a ITP-like immune thrombocytopenic purpura that you had fever and now you have a platelets going down? What is your comment on it being an ITP?
ITP will have pitaki and purpuric rashes as a presentation.
Fine. And therefore, persistent fever is not a feature of an ITP. In fact, ITP comes with some trigger and then just the bleeding. So it is not ITP. Could it be an aplastic anemia? Again, fever and platelet are down. What do you think about that? Bone marrow aplasia.
There.
No
That's
pallor.
right. So there should have been pallor more than bleeding. Okay, so this is not likely to be a platelet disorder. We discussed one type of platelet which was destroyed outside and one which was not formed. Okay, now could it be a coagulation disorder? And if this is so, could it be congenital or acquired?
So
Could it be?
coagulation,
Yeah, go ahead.
for coagulation, first of all, there is no family history, and second, there is no past history also of the similar episode. This is an 8-year-old child, so it cannot be a congenital coagulation defect.
But would the coagulation disorder congenital not present at 8 years of age? This
So
must be the
let's
first
discuss-
episode.
Let's discuss some congenital coagulation disorders which can present at a later age. Which are those? Name any one at least, just one. So from the chat, there is an answer, von Willebrand's disease.
Very good.
Right?
So keep all that in mind. Okay, but would that come with fever? Probably not. So again, you go back to that. No, that's not that congenital coagulation disorder. Could it be acquired coagulation disorder?
So if we are thinking of the high colored urine as conjugated hyperbilirubinemia, which organ is affected? Liver. Which organ is responsible for synthesis of coagulation factors?
The liver.
So could be that the two things are connected, right?
So
Sir, go on. Amdekar, sir.
Yes, the two are connected, right? So now we know platelet is unlikely, coagulation factor unlikely congenital, but could be acquired. If it was acquired, it was a liver disease. Could you tell me another cause of an acquired liver disease, coagulation disorder, besides the liver? Could a severe intestinal disorder cause bleeding?
So somebody has answered sepsis.
Sepsis could have a multifactorial reason for that, but even as vitamin K not absorbed could also do that. Okay, so vitamin K could be also the liver problem. It could be the hepatocyte problem or biliary tract problem. So far so good. We know that one cause of connecting hyperbilirubinemia or bilirubinemia with bleeding is an acquired liver disease, and it could have been a hepatocyte or a biliary tract. We have no idea so far. Let's discuss the third factor, vascular. Could it be any vasculitis? There is fever, and there is a bleeding disorder, which could be vascular. What about that? Well, vasculitis could cause a nosebleed. Okay, would vasculitis cause jaundice? That's the question.
From the chat, everyone feels that there should have been a rash in vasculitis.
Yeah, yes, but not necessarily every time the whole syndrome comes together. So don't forget now, yes, you are right. But the symptoms could come one after another. And to that extent, the answer would be, what should happen in vasculitis when the liver is damaged? Vasculitis is a localized vascular disease. Now, the liver is supplied by so many vascular radicals that all have to be really get involved before a significant amount of hepatocytes are damaged. So that is unlikely. And therefore, so far so good, we feel it could be an acquired liver problem, which is due to acquired coagulation defect. Okay, that much we know that. Okay, so now who will try to summarize what we have said so far and give me now a probable diagnosis. I'll give you again a clue. We said there is probable some viral infection. Then we said immune complication caused epistaxis, and same immune complication probably has also caused a liver damage, that is hepatitis. Okay, so now you combine all this and tell me what must be the immune process and what must be the syndromic process that we can put a label on. Come on, somebody. We have already said acquired cause. Okay, yeah. Come on, one of you. What immune-mediated disorders after some viral infection or some trigger like this you have seen?
Sir, HLS is one of the immune-mediated disorder.
All right. Okay.
So
So
from
could
the
you?
chat, people are talking of HUS. Now, HUS is hemolytic uremic syndrome, and that will not come with these presentations. You know, the first prominent feature will be of uremia and therefore of oliguria and all that. So therefore, there will be renal manifestations. It will not be fever and bleeding as a presentation.
And again, microangiopathic hemolytic anemia. So pallor would be a presentation, and there could be a platelet problem as well. Okay, but something now similar. Okay, something that you have often seen, which presents with multiple sites of involvement, not necessarily just typically liver only or a bleeding thereof, but it could involve anything. Okay.
She
And which
said
comes
HLH.
very
Kirti
good.
said HLH.
Yes. So I think what we talked about is this could be one of these three. We filtered out one by one and put the possibility of an coagulation disorder as the cause of bleeding. Okay. And that has also coming from possibly the liver. So we have such possibility and so on. And therefore, we already said congenital are required. And the provisional diagnosis will be like an HLH. Okay. See, we are not trying to give a diagnosis only on the history, but the whole idea of this exercise has been that unless you start thinking, you don't ask a positive ways of finding out more information. Okay. And we knew what we were thinking about. And for each of those, we asked questions and we filtered out what most probably that. Now let's get to the physical examination. Growth and
Sir,
development was normal. Yeah.
Sir, from the chat, there were some comments. So see,
Yeah.
you have been talking of dengue and leptospirosis and rickettsia and all that.
Yes.
So basically, you have to think of a group. That means if you are thinking of a original viral infection, then a complication, then you think of along those lines. If you are thinking of a original bacterial infection and a complication, then you think along those lines. So it's a group that you are thinking of. You know, you can't have one particular, but in all of them, jaundice is a little less likely, clinical jaundice, and that is a small difference. Yes, sir, Amdekar sir, go on.
And I think if you see typically leptospira or rickettsia, leptospira, the typical manifestation is not a bleeding disorder. So that will happen sometime maybe at the fag end. But the classical presentation is when a second phase of immune response comes in, you have a liver and a kidney gladly involved, or sometimes even the brain, etc. But bleeding is not a beginning story. That is number one. In rickettsia, yes, bleeding could be a story, but more often, even things like thrombosis and even a gangrenous lesions. Okay, in a very, very sick child. Again, bleeding from a particular area is not a prominent manifestation unless at the fag end. Whereas here, the story has started very early with bleeding. And when story starts early with bleeding, you have two probabilities. One, is it primarily affecting platelet plus coagulation both, or whether it is only the coagulation coming from the liver? Now, don't forget, in an acute liver disease also, there could be one of the functions which takes the precedence over the other. And you know that a very acute liver disease may not have jaundice at all, may not have bleeding at all. Then how does it present? Very acute liver disease. It may present with jaundice, yes, but it may not present with jaundice, and it will take some other route.
Encephalopathy.
Yes. See, typically a Reye's syndrome, which may come with drowsiness, unconsciousness, hypoglycemia, hyperammonemia, but no jaundice, no liver dysfunction apparently. Okay. And a typical slowly ongoing liver disease may pick up only with ecchymosis and nothing else. But of course, the investigation would show that some other findings are also there. So we will keep all that in mind. And though leptospira, rickettsia are all the examples of a systemic manifestation, immune-mediated, and this kind of a syndrome that coming with bleeding first and high colored urine just reported, yet not jaundice seen. So this is not a feature of the condition that we talked of, but I agree, you have been thinking rightly that you have some kind of a situation with immune-mediated disorder. So let's get to something. He's sick-looking, he's febrile, he has moderate pallor, he has a mild jaundice, he has no lymphadenopathy, skin rash, or bony tenderness. He has a liver with a span of 11 centimeters, non-tender, spleen, 2 fingers, and other systems are normal. Now, what have you got in this child? Exactly what we thought by the history. Yes, we thought that this child has
But
a...
this is there, na, still.
I could not hear her.
No. Jimmy, you want to take that, or Ramya? How do you interpret these findings? Yeah, Jimmy. Yeah, Jimmy.
So this child has a normal growth development nutrition, which means that the child was normal beginning of the disease. He was not under any. He didn't have any chronic problems. So it was an acute problem which he is facing, and he's sick looking. Most probably, it looks like a bacterial infection in which the child present very sick. That points out towards the bacterial infection. And he has moderate pallor, mild jaundice, which also, according to the discussion we had, it points out to a coagulation problem and a liver involvement. And he doesn't have any bony tenderness, which rules out conditions like leukemias and all. And he has hepatomegaly and a spleen. So
At this point, do you think we missed the whole boat? But this is an acute viral hepatitis, which is worsening, and therefore the bleeding because of coagulopathy out of a viral hepatitis. Short duration illness, 8-year-old, typical story. What do you think?
So the child would also have complaints like nausea and vomiting along with fever in viral hepatitis.
All right. Okay.
So that is one reason that the prodrome was not there, but some 2 or 3 other strong reasons.
Anorexia is also a presentation in hepatitis.
Sorry, Ramya?
Anorexia to eat.
Which is what Ketki said, anorexia, nausea. So I think the chat has answered. The liver here is non-tender, whereas in viral hepatitis, it has to be tender, acute viral hepatitis. And plus they have said why the spleen, why the pallor, and therefore it's unlikely to be viral hepatitis.
And typically viral hepatitis, which is ongoing like this, would have jaundice as a predominant manifestation on the history itself. this child has mild jaundice picked up by physical examination, but not really to start with. So many reasons why this is not a viral hepatitis, but yes, the hepatitis, because inflammation of the liver cells caused by the immunological disorder. So I think so far we are reasonably on that. With these kind of findings, one could have started thinking of leptospira, etc. But we have already talked about how this profile of syndrome coming up in symptom complex does not fit in many of such things. Now, let's see the
From the
yeah.
chat, somebody is suggesting, can it be hemolytic anemias like sickle cell and hereditary spherocytosis? So what are students, you suggest first whether you want to consider that?
So it might be hemolytic anemia because sickle cell, for example, sickle cell anemia, when some viral illness is act as a trigger factor, there might be the crisis phase where bony tenderness might be there, hepatosplenomegaly might be there, and because of the hemolysis failure and jaundice can also be present at that time.
Good. Now tell me, does hemolytic anemia like sickle or spherocytosis come with bleeding?
No, sir.
Fine.
Can
Then
they
why are
come
we
with
thinking about that?
thrombocytopenia? Can they come with thrombocytopenia?
Yes, sir, they can. There is
How?
sir, uh, acute hemolytic anemia plus thrombocytopenia is seen in Evans syndrome.
Okay.
Okay.
What else? So somebody from the chat has answered hypersplenism. So true that hereditary spherocytosis may occasionally have hypersplenism. But the point is these thrombocytopenias do not translate into clinical bleeding. And that same is the answer for earlier someone asked, could you have taken ibuprofen for the fever and that has caused bleeding? So these are very rare that, you would get a drastic thrombocytopenia and lead to clinical bleeding due to that. Yeah, Amdekar sir.
Fine. So I think most of these hemolytic anemia don't cause bleeding, even if there is a suppression of platelets out of aplastic crisis. Sometimes you might have a thrombocytopenic, but at the most a purpuric spots here and there, nothing more, but not otherwise. So we are now reasonably sure that this child has a hepatitis, which started as a bleeding disorder out of some infection going on for a long time, which we presumably called not bacterial, but possibly viral. Now, could it be totally a non-infective condition only? This was only an immunological fever. Okay, one of the systemic inflammatory disorders. Could it be that? So, rheumatological disorder. SOGIA?
SOGI does not fulfill the criteria, sir. Quotidian pattern of fever and the duration of the illness only 8 days.
Fine. And therefore, all that we could have said is we could have thought of a vasculitic disorder, collagen vascular disorder, not the rheumatological inflammatory disorders. But when it came to liver and affecting large part of hepatocytes, we got out of that and we said, no, not probably a primary vasculitis. Otherwise, a disease like a Wegener's granulomatosis is a vasculitis which can come with epistaxis and high fever, but generally would not cause a hepatitis-like syndrome. And we already said why a vasculitis may not cause jaundice per se, and therefore we boil down to say that this must have been possibly what we have been thinking about HLH. Now look at these investigatory findings. Hemoglobin 7, WBC 6,000, normal differential, platelet 65,000. Oh, ESR is normal. We are in trouble. We don't have such immune-mediated inflammatory disease at all. How can ESR be normal? And see further, just normocytic anemia, bilirubin slightly raised, but direct, yes. ALT, AST are also slightly raised. That is a part of hepatitis. Oh, ESR bothers me. What is your comment on that? So now all along we have been thinking of HLH. We discussed various ways. Can ESR be normal in HLH? Such an inflammatory disorder?
ESR can be normal initially, sir, in HLH.
Why is that?
Why?
The
Now I will tell you, CRP in this child was very high, but ESR was normal.
Actually, sir. Actually,
So what does ESR depend on?
depends on
One cause of low ESR,
Fibrinogen.
so fibrinogen. And is low fibrinogen a accompaniment of HLH?
Yes, sir.
Yeah, there you have it. Right?
Yes.
So I think what we learned in this child was first how we start thinking about the history itself. That gradually leads us to start with details of fever, then get to vasculitis or coagulation or platelet, then filter one by one and give a probabilities one over the other, and then catch up with the subsequent progress and also the physical findings, right? So this was hesitant. We wanted to bring out not a simple ITP or something. I'm sure you're all extremely good at that. And I wish you get only ITP in the exam. Okay. But if you get something like this, you still are ready to go by, right? Any questions on this? Otherwise, we get to the second case. Rajesh, you have anything more to say on this?
Yeah. No, sir. So from the chat, someone is asking, can we consider HLH so early in the course of an illness?
Yes,
So,
yes. Answer is yes. Okay.
Yeah, sir, go on. Yeah, go on, Amdekar, sir. Just explain that, sir.
In fact, the answer is yes. In fact, we need to pick up immune-mediated complication as early as possible. But the person who has asked the question, I must say that not all organs will be involved one after another in a short period. And there could be a scattered way of presentation, especially if you interfere with the management. To that extent, HLH must be considered pretty early in the course of disease. Today, we start discussing a probable Kawasaki even at the end of day 3 or day 4, though the books would say 5 days of fever and the rest of it. But that doesn't mean that you do not start thinking about it. For example, a child has fever in between, he is okay, but he's very irritable, cranky, okay. And you are worried, why is so cranky? Oh, at that stage, you might even start thinking about it. You may not be able to pinpoint it. It takes time for the evolution of the disease, yes. But this child, by the time we saw, has gone past 8 days of fever already. Yes, you're not going to wait anymore now to even consider, but we showed you how we could consider it systematically by discussing every other part of the story, right? Okay. Rajesh, shall we go for the next case?
Yeah. Yeah. So just
Let me
one
give
more
you a-
question.
Yeah. Yeah.
No, there's one more question from the chat, that should we consider before the investigation
No, I did not hear you.
result, should we consider it against that is come with bleeding manifestation? It wouldn't present with bleeding manifestation.
No,
So
the
that
point
is
that
why
yeah.
you would keep it less.
Yeah,
Yes, sir.
you're right.
Amdekar, sir.
In fact, the first probability was an acute vasculitis, like a Wegener's coming up. Okay. And we would have waited for some time. But when jaundice came, and that to direct bilirubin, we said this very syndrome is also affecting the liver. That's where we started going away from vasculitis and come back on coagulation. You're right that, but this is the fun of medicine, that everything doesn't present. In fact, you must have seen every kind of a disease presenting not a book picture, but something very different. And I think even then, you can start with something else in your mind, but as you go further, you start deviating from what you first thought. And one would have been right to consider vasculitis local inflammatory, therefore could be like any other syndrome, but like a typical Wegener's. And then move on further when the jaundice came, that, oh, we are moving away from vasculitis, right? So you are right, absolutely, that why should you start HLS to begin with? No, you should have thought of vasculitis to begin with. All right? Fine. So shall we go ahead, Rajesh?
Yeah.
Let me put you on another
Yes,
case
sir.
now, and
Yes, sir.
we will again do a similar thing, okay? This is an 8-year-old healthy child presented with fever and throat irritation for 3 days. This is exactly what the child said. Fever got controlled at the end of 3 days, but it followed by a skin rash on both the legs. Now again, start thinking properly. The first child had a continued fever when bleeding came. This child, we don't know whether it is bleeding or not. Some skin rash coming after fever has disappeared. Now start asking questions. But this rash is only over the legs. Now who will ask some more questions?
And abdominal symptoms also, sir?
There are no other symptoms. So again, the fever has already disappeared. So you have already known that this was not a fever of any concern to us as of now. Okay? We don't know whether this fever will come back again. Theoretically, yes, but certainly not a bacterial fever or an immune-mediated fever to start with. It would not have disappeared in 3 days. So we'll call it a viral infection for the sake of discussion. Now, which viral infection come out rash only on the legs when the fever has already disappeared?
Thank you, sir.
Pardon?
Didn't consider, sir.
Okay.
Sir, she's saying HSP. There are answers from the chat also. So everyone is asking whether the rash is palpable and purpuric.
Very good. So you would have asked all those questions, and the answer is yes. Okay, answer is yes.
But tell me, why can't it be a simple viral fever which is often followed by a rash? You
Limited
get
on,
so many viral fevers. Yeah.
limited
Yeah.
only on legs.
Okay. What else?
So the viral fever, the rash usually occurs along with the fever. Here the fever has subsided and then the rash has occurred.
Actually, you get two types of viral fever. A viral fever and rash coming together. Example is chicken pox, and a viral fever ending and then a rash coming, many non-specific viruses, including German measles and many others. So you have both patterns, right? So one important thing, as Ramya said, is in them the rash is generalized. And the second, of course, you have to ask for the type of rash, that what did it look like? So it looked like faint red patches all over the body, which disappeared. So maculopapular. Whereas here you are all asking about different appearance of the rash. Yeah.
Now the other rash that comes typically over the legs only is an erythema nodosum. Okay. Could it be an erythema nodosum? That's typically seen over the shins. Okay. You might see over the elbows, yes, but very commonly over the legs. So do you think it could be an erythema nodosum, which could be triggered by multiple types of infections? One of them, of course, is also tuberculosis. And this fever disappeared, might come again and become fever off and on. Might be TB. What is your take on that being an erythema nodosum?
So, sir, from the chat, they said they are painful.
Excellent. So you also asked whether the rash is painful or painless. Wonderful. And of course, they are almost a small bumps here and there and not much of a rash. But yeah, so let's take it further now. Skin rash was macular erythematous that quickly turned into blanching red papules over the next day. So you're right that you are thinking of that. Now, what do you make out of this now? So you already got some purpura there. Okay. And in which the fever has disappeared. In the last case, we said it was a vasculitis and the fever continued. So what do you make out of this?
Yeah, so one you said, all of you said HSP, so that stands. Now there is a question, someone has said from the chat, if child is sick, it can be meningococcemia.
Oh, very good. Very good. Could it be meningococcemia?
So, but the fever has disappeared and the child,
Correct. The child would have not just got out of fever at all. And in fact, the child would have become very sick. Plus, the rise of meningococcemia comes almost in the first 12, 24 hours of life. And it's a very fastly progressive disorder. And if you do not pick up in the first 24 hours, the child might be dead with a severe adrenal failure. And he is lucky to survive if he gets a meningococcal meningitis. But the rash comes very early in the course of disease and the fever doesn't go away. Could it be a simple ITP? Why go into all those details? Fever came, disappeared, purpura came. Simple ITP, no? Why are we complicating? Just because I said you will get ITP and we will not discuss ITP. And it was just a trick that I played with you. I wanted to play ITP only. But before that, I said, no, ITP is simple. We will not discuss today.
so, but
Typical ITP, no?
Yeah, Ketki.
so it can be ITP, but it won't be just restricted to both the legs. And
Very
there will
good.
be
And
they
what
can-
else? What
There
else?
Something else.
bleeding from some gum bleeding or mucosal bleeding will be presented, and the child will be non-sick looking.
So bleeding from gums is not compulsory. Maybe there, may not be there. This child is also not sick. But go back to any ITP case that you have seen, and what did the child come to you for? Chief complaint, presenting complaint.
The child came with the complaints of rash, sir. Fever
And
was
almost never with fever as a chief complaint,
yes.
right?
Yes.
Fever has disappeared already, right? So this is not then an ITP. So we will take a note of that this is not ITP. Now these are red papules. What do you mean by a papule?
Less than 3 mm size palpable lesions.
Fine. So which is palpable purpura? I thought purpura is not palpable. Purpura is just small red spots, pin-like spots. Okay. So this is palpable. How can you call it purpura?
So what is the clinical significance of that palpability? What does it lead you to?
Vasculitis.
Excellent.
Very
Vasculitis.
good.
Yeah.
So we know that this is a vascular purpura. Okay. And now we start looking at which are the different vascular purpura. So now ask more questions about vascular purpura. Somebody said it could be HOS. ask questions about finding whether it could be HUS. What more do you want?
Is there pallor, sir? We would.
All right.
Yeah, okay.
Okay. So let's
Whether
see.
there is.
Yes. So let's see what
Whether
this child. Yeah. So 2 days later, developed a right knee joint swelling. Okay. Could it be an SLE? Okay, I have not told you whether it's a male or a female child. You have a vasculitis as one of the manifestation of SLE, and you have now a joint swelling coming up. What do you think about that? Any thoughts on that?
So they are saying that
What
the
type
rash
of
will be more on the face rather than only on the leg.
All right, all right. And typically, a big joint monoarthritis is not a feature. Okay. So, persistence of fever. So, multiple reasons why this is unlikely to be that. See what happened. Had severe abdominal pain and bloody diarrhea. Now, where do you get all this from?
HSP.
HSP, sir.
So now you know that this is likely a bleeding elsewhere, also in the intestine, in the joint, etc. No past of family history, and therefore you have already said what this is likely to be. Okay, let's see the physical examination on this child. He's not sick looking, but he's irritable. Okay. Why is he irritable?
Because of the abdominal pain, sir. Could be-
Excellent. Excellent. So there is some pain somewhere, and there is an abdominal pain. That's why he's irritable. He has a palpable purpura, no other bleeding sites, mild swelling of the right knee joint, not much severely inflamed. Other joints are not involved. Abdomen is soft, mild generalized tenderness, and nothing else. So possibly you got a diagnosis of an IgA vasculitis, right? What investigation do you want in this child?
Come on, what will you find on investigation, or what do you want to do as an investigation? So from the chat, they are saying USG abdomen to rule out intussusception.
Very good. All right.
And CBC. So what will the CBC show?
Oh.
Yeah, try. Jimmy, you want to try? It's a inflammatory disorder, no? So what is possible on CBC?
Counts will be elevated, ESR will be high,
Okay.
and there will be anemia. Could be anemia because of vasculitis.
Okay.
We can do a
Yeah.
peripheral.
Yeah. Yeah, we can do a peripheral smear. What will that show? So basically, there will be non-specific signs on CBC. So you'll have thrombocytosis, you'll have leukocytosis, but they're not pointing to anything specific, right? ESR can be raised.
Which other organ you are worried about? That might even change the prognosis of this child?
So, sir, from the chat, they said they'll do urine routine for hematuria.
Fine, we must do that. Okay. In fact, the prognosis might change. But don't you want to do immunoglobulins? We have an IgA vasculitis as a provisional diagnosis. Don't you want immunoglobulins?
So, will it be IgA high, IgA low, or there is no connection? What do you think, Shashidhar? So basically, there'll be, means IgA can be increased, but there's no connection of that. So you don't do a IgA level to diagnose or prove that this is IgA vasculitis.
So then how do you diagnose this condition? You said CBC, ASR, CRP non-specific, ultrasound normal, you have ruled out intussusception, you have looked at urine, so far fine. But how do you diagnose IgA vasculitis?
So again, from the chat, they have said skin biopsy to show IgA deposits.
So
but
would you do a skin
clinical diagnosis?
So I think we'll reserve skin biopsy only in case of doubt. Otherwise, this is a clinical diagnosis. And skin biopsy will show, yes, a typical antigen antibody complexes, but it will not tell you the etiology. For example, this could be a manifestation of even a lymphoma coming up. Okay. But normally in this situation with a clinical syndrome, we will stay put till otherwise. And what do you expect in this child? What treatment and what prognosis?
So they have answered from the chat steroids, but our question is steroids for everybody with HSP? Who will answer that? Correct. So only if there are severe abdominal or renal issues, not for everybody with HSP, right? And it will not alter the course of the disease.
So in general, no treatment, symptomatic pain, and wait and watch. How long would it take for this child to recover? And will he recover completely? Or would he be left behind with some damage to the joint, maybe develop renal disease, already has got an intestinal disease? What is the outcome of such a disease? So outcome is generally very, very good. And it takes sometimes 4, 6, or even 8 weeks to get better. Especially abdominal pain could be very difficult to control. But ultimately, the majority will just get well. And those who don't get well or even get worse over time, you start looking at whether this is another type of vasculitis that you are going to hit on. And then you need a skin biopsy or many other situations to go by. Otherwise, almost always there is a good outcome on this child, right? I think we will ask you some pertinent questions about bleeding disorders in general, okay, unrelated to even these conditions, and just quickly revise some of those things. We have already discussed this. Which are the conditions where there is the thrombosis and bleeding both together? First thing, do you believe both can be together?
Sepsis.
Two are totally opposite of each other. Okay.
Sepsis.
One is bleeding, the other has got clots there.
So sepsis or
Sorry, Ketki, we couldn't hear.
sir, in case of sepsis or
Very good. So what you mean is DIC, right? disseminated intravascular coagulation. What else can cause bleeding and thrombosis together?
Sir, they said TTP from the chat.
Very good, very good. Thrombotic, thrombocytopenic purpura. Yes, the name itself says you have both of them, right? Very good. And any infection that we talked just half an hour ago, which has also bleeding and also thrombosis? Rickettsia. Okay. But now tell me, why should these two things go together? How can two things go together? You have seen Yeah, go ahead,
Yeah,
Ketki.
Ramya, you were saying.
Yeah, Ramya, go ahead.
So microangiopathy is a small vessels injury leading to formation of the thrombus, and because of the local consumption of platelets, bleeding manifestation.
Excellent, very good. So thrombosis leads to bleeding because of consumption of platelets, and it's not the bleeding that causes thrombosis, but thrombosis causes bleeding, and that's how two are often separate entities but can get together, and we have said this already. Well, I think Ketki or somebody talked about Evans syndrome. Anything else where you may have hemolytic anemia with bleeding? Evans syndrome is an inherited problem, right? And HUS itself, your microangiopathic hemolytic anemia, you said just now, and that's also both having anemia and bleeding. What are the immune deficiencies presenting with bleeding?
HIV.
Pardon, somebody said something.
HIV, they said.
HIV. No.
But from the chat, correct answer, Wiskott-Aldrich syndrome.
Correct.
Yes.
Wiskott-Aldrich and Chiriac-Higashi. Okay. So just keep in mind, I'm sure I'm not very much in favor of asking such questions because they test your memory more than knowledge. But when you have reached some stage, they might test your memory also. Till then, it is the knowledge only. And we have been discussing that. Okay. Which are the bleeding disorders where everything is normal? PT, APTT, and platelet. Screening tests. All screening tests are normal.
So factor 13 deficiency.
Okay, very good. Good. What else?
1 milligram factor.
Yeah, very good.
Good. So you have factor 13, platelet functional disorder, and child abuse. Right? Good. Rajesh, any more things to talk of or any other students wanting to talk?
So just one or two clarifications. So
Yeah.
hemolytic anemia was not meant for Wiskott-Aldrich. Hemolytic anemia with bleeding was a different question, and immune deficiency with bleeding was a different question.
Yeah.
So we are not saying Wiskott-Aldrich causes hemolytic
No.
anemia.
No,
Okay,
no,
so
no,
don't
yeah.
get confused in that.
Yeah.
And somebody said hypersplenism as a cause of hemolytic anemia with bleeding. So we just talked about it, that usually in hypersplenism, the thrombocytopenia is only detected on investigation, but they don't result in clinical bleeding. Okay, fine. Any other questions related to the cases today or anything? Okay. So fine. So we'll stop here and we'll meet again next Wednesday. We'll probably have hepatology related cases for you to kind of read up and be prepared and come. We once again want you to...
Rajesh, I have one request for you. Let 4 students volunteer to begin with and present their own cases so that they feel comfortable and they put up for a discussion. Because when we put up our virtual case, they are little disturbed on not being very secure to come on the platform. Could 4 of them in a pair of 2, okay, 2 pairs, deciding 2 different cases that they have seen or they have heard, whatever details you must have heard. Is that a possibility,
Sorry,
Rajesh?
Sir, sorry, I lost you because of poor internet. But I think you are
Okay.
saying that we decide the discussions beforehand. So what I'm
Yeah.
going to do is we've made a WhatsApp group of these people, and please tell your friends who have registered to also convey their mobile numbers to the IAP office. So a few are still to be added to that group. So we will decide the discussions beforehand only. You please
No,
volunteer.
Rajesh, I also thought that these very discussions should bring their cases.
Yes, sir. I'm coming to that.
Yeah.
So the second thing is that now that we are saying hepatology, if anybody can bring a hepatology case and present it, we would first take your case as a discussion case. Our virtual cases are only for backup. So please start presenting cases. That will give you really a lot of practice. Okay. So anybody can come forward and present cases. And we are talking about a particular system.
Rajesh, the other thing is,
prepared and confident, though there is no need to stick to a system.
the other
Yes,
thing
sir,
is,
Amdekar.
we have 2 sessions next week. So one is on neurology following, right? Am I right? So ask them to also get 2 cases for Friday for neurology and 2 cases for hepatology on Wednesday. If possible, that would be wonderful.
I mean, Dr. Udani is an excellent teacher, and it would be a great learning if you can present a neurology case to him. So please bring any neurology case. It may not be related to the topic, the theory topic that is going here on day 2 of life, but you could bring any neurology case and present to him, right? So please do that, and please tell your friends to convey their mobile numbers to the IAP office. And I was told that the Vadia session will get over by 2:30 today, but apparently it didn't get over, so there was some overlap. Doesn't matter, the recording of today's sessions will be available to all registered people. As soon as our website starts getting, all these sessions will be put on our website only. Okay, so thank you very much. We meet next Wednesday again. Thank you.
Thank you.
Thank you.